Dr. Kinsella is board certified in internal medicine, neurology, neuromuscular medicine, electromyography, and autonomic disorders. He is a fellow of the American Academy of Neurology. He is a native of St. Louis who completed internal medicine residency at St. John's Nursing in St. Louis. A neurology residency at Brown University in Providence, Rhode Island, and a neuromuscular EMG fellowship at Columbia University in New York. He has special interest in neuromuscular disorders, EMG, and autonomic disorders. He is currently the Director of Neurology at the Neurosciences Institute here at SSM Health St. Clair Hospital. Please join me in welcoming Dr. Laurence Kinsella.
Thank you, Brad. Hi, everybody. I don't always wear a bow tie on Saturday, but I'm feeling a lot of pressure to keep up the whole bow tie thing, so I thought I'd better wear one today. This is Dysautonomia Awareness Month. It's normally should be a turquoise tie, but I thought about that last night when I was cooking. I teach spinning classes at the YMCA, and so I had packed up the night before, and so it didn't hit me until I walked in this morning in a turquoise tie. In any case, how many of you are patients, suffer with this illness? How many of you are caregivers? Gotcha. So we have about an equal number of each. So what I'm going to talk about today is some everyday POTS management, a top 10 list, but obviously there's more than that. But this is a start. And you've heard from Dr. Quattromani and Dr. Weinstock on some of the science behind what we do. I'm not going to talk as much about those sorts of things. I'm going to talk mainly, focus on the practical tips that I go over with most patients with this illness. There are also some wonderful suggestions contributed by Brad and Jenny and Kelly on the POTS website. If you haven't joined the STL POTS Facebook page, there's a lot of great information on there, and how to make your own electrolyte solutions, and how to use the ones you can buy, and there's a variety of great suggestions there. But let's go over a few things that I talk to people about, and hopefully I have the slide up. There we go. Okay, no input detected. Here we go. Maybe that's because I pulled on that and made a mistake. So we'll give it a chance. And let's see, what's it, date? No? Okay. Okay. Wonderful. Okay. Thank you. All right. So this is a drawing that a patient of mine did, talking about all the organ systems in her body that seem to be affected by her POTS, by her symptoms. And you can see it's a very extensive, very diagrammatic view of the types of symptoms that people are likely to have. There really is no part of the body that doesn't seem to be affected. And
Arrows on the bottom right.
yeah, hang on. Okay, here's another patient's symptoms. This is actually one of my first patients I saw with POTS, and she had been doing reasonably well, but then had a relapse. And she sent me an email as to all of her symptoms. I asked, is it okay if I make a list of these symptoms? And so you'll forgive me if, as a physician, and your physicians may feel a little overwhelmed by a list like this, right? This is a daunting list. Where do you begin to help somebody with this sheer volume of symptoms? And it covers every imaginable organ system. And how many of you have heard, it's all in your head? Right? That's a very common thing that patients with POTS hear. And it's very difficult for physicians, and so you need to be a little bit, I know that you've heard that, and it makes us angry and resentful. But keep in mind that physicians need a biologic model to understand things. And when we see this kind of a symptom list, it makes us think, oh my goodness, where do we begin to manage this kind of list? So be patient with doctors. They're coming along. We're dragging them into an understanding of these very complex medical illnesses. But it's a process, and we need a biologic model. And the biologic model that's helped me the most understand this is functional MRI scan. That what we've learned from Iraqi war vets who lose an arm, nobody told their brain that arm is missing. Their brain still thinks they have an arm, and not only do they still have an arm, the arm is distorted, it's swollen, it's twisted, and it's exquisitely painful. And it's a very common experience to have the patient tell the surgeon, hey, after they've removed the arm, can you go down and scratch my arm in the morgue because it's so itchy, even though it's not attached anymore. So we know from functional MRI, we can actually see those neurons that were devoted to that arm. They're still there, and they're now misfiring because they don't have an end organ anymore, and so they are misbehaving. And so we see that on MRI. We've now learned that the most effective therapy for phantom limb pain, which is what we call that, is a mirror. That if we have the patient look into the mirror and move their good arm so they can't see their missing arm, move the good arm and show the brain those neurons that were devoted to that in the reflection, they can actually calm down and they can actually reduce their pain. And we're now extending that same model to understand many of these other very difficult syndromes and fibromyalgia. How many here suffer from fibromyalgia? Functional MRI has been very helpful to understand that disorder. That we see that even though the joints are calm, there's no soreness, they're sore, but there's no redness, there's no swelling. The brain that you look at the brain activity and it's as though there's a 4-alarm fire going on in the brain. So this central sensitization which occurs, the amygdala, frontal lobe, locus coeruleus, these areas are literally on fire. They are firing like crazy. So functional MRI has helped physicians, has helped scientists apply a biologic model that helps us understand why somebody would have this extensive list of symptoms. When a patient comes to see me, I run through an autonomic symptom review. I'm looking for other symptoms that go along with the orthostatic lightheadedness. So this is sort of the classic feature of patients with POTS. They literally cannot stand to stand. They have orthostatic lightheadedness whenever they're standing up. And we classify it as never, mild, frequent, consistent, meaning every time they stand, or number 4, when they stand they also faint. We ask about heat and cold intolerance, blurred vision, palpitations. These are other features that occur when people develop orthostatic lightheadedness. We ask about anxiety and shakiness, tremulousness. If your adrenaline levels are going through the roof and your heart rate's going through the roof, you're going to feel a little anxious. Dry eyes, dry mouth, headaches, migraine. Initial reports were only about 25% of patients with POTS had migraine. We now know that it's more like 80%. Most of my patients with POTS have migraine, and a key feature of managing this disorder is to manage the migraine. Now, this is really something I call the symptom snowball, that when patients come in with this very long list, what happens is these symptoms multiply and they amplify with time. We call this somatic hypervigilance, that we become, the more symptoms we have, the more likely we are to pay attention to new symptoms, and we actually create more. And this is akin to something very common to physicians. How many of you have ever suffered from phantom cell phone syndrome? I see the guys raising their hand here too, because it's the guys that have the phone in the back pocket, right? And you think that it's gone off, and you go to check it, and nobody's called, there's been no text, you didn't get a phone call. And so what is that? That is the brain making a wrong guess. This is a common phenomenon that affects everybody to a different extent. And once we become ill, the brain can make lots of wrong guesses. Some of them, but it's often difficult. It's tricky to know how much of these are are based on some serious neurologic abnormality that's going on, and how much of this is simply the phantom cell phone syndrome. So as I mentioned, migraine is common in POTS, and there are a number of dietary triggers that we talk about in managing patients with POTS as well as their migraine. And the first thing is we want to get rid of the dietary triggers. These are things that secrete tyramine in the body. These are things that contain caffeine, chocolate, alcohol, estrogens, aspartame, citrus, bananas, nuts, hard cheese, many others. I know all your favorites are on here. But so this is a very important aspect of kind of turning down the volume on these symptoms and getting some of the excitotoxins out of our diet. The other problem that we have to deal with in POTS is deconditioning. If you are lightheaded every time you stand up, guess what? You don't want to do much. You're on the couch, you're not able to take care of your families, you're maybe not even able to work. And so what happens is we become rapidly deconditioned. So the prevalence of deconditioning is well over 90%. Quality of life scores are often very low, on a par of somebody with end-stage COPD, severe emphysema. These are folks who are can function at a very low level. So the key is a graded exercise program. When I say graded, I mean starting with baby steps, starting lying down on a yoga mat with your feet in a floor peddler, which you can buy for about $25, $30, and starting with something very simple, and then gradually building up to a recumbent stationary bike or swimming, and then ultimately getting up to a treadmill so that you can begin to resume your previous activities. Weight training is also very important to make our muscles better pumps for blood back to our heart. So, top 10 list of everyday POTS strategies. I have them listed here. They include fluids, salt, compression devices, exercise, diet, medication, cooling vests, mindfulness, CBT, and education. Knowledge replaces fear. So let's go through volume expansion. This includes salt and water. The recommendations vary, but about 5 to 10 grams of salt per day is a reasonable start. 1 teaspoon equals 6 grams of salt, or 2,300 milligrams of sodium. 1 to 3 teaspoons of salt per day is generally what I recommend patients do, along with 2 to 3 liters of water a day. Drink non-caffeinated beverages. Water, sports drinks, milk, juices, soups, all those are good. The goal is colorless urine. Now, part of the problem is, if you're drinking that much water, you're pretty much married to your bathroom, right? So that's why salt is important, because the more salt, the more you can hang on to that water, and you're not having to urinate every 5 minutes. It's okay, I'm a doctor, I can say urination, okay? All right. So here's a to-go bag. So I've interspersed some of Brad's slides that he gave a wonderful lecture last year, if you were here. Some very practical tips on what Brad does and Jenny to help manage Brad's illness. And this is his go bag. And this is a backpack that's always packed. It goes everywhere with Brad. It contains everything he needs, including water, salt, snacks, which include nuts and protein bars, meds if he needs them, sunglasses, noise-canceling headphones. I love that one. Cooling towels, hydration salts, compression, stockings, collapsible chairs, brown paper bag. What's the brown paper bag for?
My breathing gets kind of wonky sometimes.
Okay. I thought maybe it was a airplane bag.
That's something special.
Okay, gotcha. So the other thing that's helpful is compression devices. There are a number of compression devices. Now, if you still have a pair of those white TED hose that you had in the hospital, those aren't going to do it. Those are only 10 millimeters of mercury. They're fine to prevent DVT, clots in the legs, but they're not going to do what you want them to do. So you need 10, 20 to 30 millimeters of compression. These are also called medium compression stockings. You can go higher, you can go to 40, but most people can't get on 40 millimeters of mercury. They're just so tight. So I usually recommend 20 to 30 millimeter of mercury knee-high stockings and an abdominal binder. Even better, though, is if you can tolerate a compression garment. And you can buy these online. They can go all the way up to the chest. And all of this will just squeeze the blood back to the heart to make it easier for you to stand without getting so lightheaded. Another thing I recommend are cooling vests. There are a variety of these, also at various different price points. Some you actually load with ice packs that you leave in your, just like the ice packs you stick in your cooler when you go on a picnic. These are things you can leave in the freezer and then load them into your cooling vest. There are others that are even electronic, so the more expensive they are, the fancier they are, but I'm not sure that they work any better. Has anyone used cooling vests? Anyone? How about, has anyone done compression devices? Okay, so much more likely. Okay. Nutrition. So here again is Brad. This is Brad sitting preparing a meal. These are pre-cooked or readily available meals. They're often easiest to make, particularly if you're having to do these things yourself. Hard-boiled eggs, jar oatmeal, washed and cut fruit. Eat natural, clean as much as possible. Small meals. Brad eats 6 meals a day. That's actually helpful to eat small meals as opposed to 3 big meals because you're less likely to shunt blood to the gut. You're less likely to get postprandial lightheadedness. So smaller meals spread out is a little bit more physiologic and better for those of us who develop dizziness and lightheadedness with standing. So we mentioned the exercise earlier. It can be very difficult, especially at first, to start small. So start small and build it up. Don't forget the importance of building strength and flexibility. The thing I usually recommend is this to my patients. Start with a stationary recumbent bike. Even better if it also has, as in this case, this is Brad's bike, it has a rowing machine component. So you have 2 different exercises for the price of 1. Doing some weights, both upper and lower body, bands can work just as well. So short-term exercise training in POTS increases fitness levels, it increases blood volume, cardiac remodeling. We start off with these very deconditioned hearts. The heart muscle actually becomes thin in POTS. So we have to build that up so to make our heart a better pump to push blood where we need it, which is the brain. It normalizes sympathetic activity and decreases orthostatic tachycardia. And the Levine protocol, Dr. Ben Levine in the Texas Heart Institute identified that a graded exercise program, meaning you start low and gradually build it up, is more effective than propranolol, more effective than the meds we use for the management of POTS. I usually tell people to obtain a heart rate monitor, a Mio, or a Fitbit, or others. I'm not a big fan of the chest strap, just because I used to use them all the time until I started getting rashes from them, so I just use the wrist strap. I use a Mio, I think it's the most accurate. You then calculate the 75% of your maximum heart rate, which is 220 minus your age times 0.75, and you could do that calculation and say, I can do that just sitting here. But it's actually, standing up, it's easy to get your heart rate up, but sitting or lying down is harder. So the goal here is to get your heart rate up to 75% for some period of time, 3 days a week. And we usually start with 3 minutes. But you can start with 1 minute, you can start for 10 seconds. The goal is to get started though, and to gradually add time to that as you go. So begin with non-weight bearing exercise. My favorite is the stationary recumbent bike, but I have some patients who can't even stand to sit up. So I have them lay down flat on a yoga mat and use something called a floor pedaler instead. And there's a resistance knob that you can add more resistance to it. Rowing machine, swimming are also helpful sitting down exercises. So we start with 2 to 3 minutes of warm up. We reach our base pace, which is 75% of the maximum heart rate for 3 minutes. We do 1 to 2 minutes at 25 to 50% max heart rate, and then we get back up to 3 more minutes at base pace, followed by 5 minutes of cool down. This may be too much to start with, so do what you can. We do this every Monday, Wednesday, and Friday. Every week we add another minute to the base pace, and once you're at a total of 30 minutes, you can then graduate to something more upright, maybe a spinning bike, maybe a treadmill or an elliptical, or going out for a brisk walk with your family. On Tuesdays and Thursdays, we recommend people use the weights. Exercise improves physical and social function better than propranolol. These were the results from Dr. Levine, and he showed that exercise training improved social functioning as well as physical functioning. I mean, they're just absolutely hands down better than medication. So, as you all have already discovered, yes, medicines help, but they're not the whole story. We have to have a multimodal approach to fixing this problem. So, treatment approaches, we've talked about things that increase blood volume, oral water, increased salt, food to cortisone. How many of you are on IV saline? Okay, some of you. As you all know, those of you who know me, I'm not a big fan of IV saline. I just think it sets up a dependency state. I'd rather you be independent and not have to depend on somebody placing an IV in your arm and giving you a... But there are times when it is necessary. I have a patient who absolutely cannot tolerate swallowing because of her severe diabetes and gastroparesis. She always vomits, so she's one of the people that we do IV saline for. I won't get into this. We had sort of a point-counterpoint with Dr. Q last year. I thought it was a very helpful discussion, but I think that's a conversation we should save for another day. Hemodynamic agents, there are a variety of medicines that are out there for assisting with the return of venous volume back to the heart and back to the head. They include midodrine, propranolol. The key here is low dose, 10 milligrams, maybe even 5 milligrams twice a day. I like propranolol not only because it slows the heart rate down, but it also is a great migraine prevention drug, so I get to kill two birds with one stone, if you will. Pyridostigmine is a drug we've been using for years for myasthenia gravis. It turns out it's not bad for POTS because it forces more acetylcholine to allow more release of neurotransmitters that help support our blood pressure without causing our lying down blood pressure to be too high. So some of the medication options, I've mentioned a couple, but there's also Florinef, which essentially forces your kidney to hang on to more water. So you gain about 5 to 6 pounds of water weight, and that prevents the blood pressure drop from occurring. It also helps slow down the heart rate. SSRIs, sertraline in particular, Zoloft, has been used in low doses for the treatment of POTS. Methylphenidate, I occasionally use stimulants to help a patient manage not only the low pressures, but also the fatigue that individuals develop. Ivabradine is a very novel agent. I have some patients who cannot tolerate propranolol, and so ivabradine, also known as Corlinor, is a new novel agent that inhibits a current in the sinus node of the heart. So it slows down the heart rate without causing the heart to pump less efficient, to be less efficient. So I have had the opportunity to use this in a few patients with success. Clonidine can also be used particularly for people who have diarrhea at nighttime. I'm mainly using this in my diabetics. And then you've heard from Dr. Weinstock about mast cell disease. I use a mast cell cocktail when I think that may be a problem. And so these are H1 and H2 blockers that can be purchased over the counter with the exception of cromolyn, also called gastrocrom. But fexofenadine, that's Allegra, ranitidine, these are all available over the counter. Mindfulness. So learning to manage our attitude, our mindset, this is absolutely critical to our success in any chronic illness. Because let's face it, we're living with chronic illness. And while we're waiting to get better, and we all have maintained hopefulness that we will get better, we want to manage our day-to-day symptoms as we're going. So this again is from Brad from his talk last year, and I think this is great. So I'm just gonna, I've reprinted it for your syllabus so you can read this on your own. But attitude and mindset are the most effective therapies of all. And own it, accept it, and move forward. Fight each and every day. And you will get knocked down multiple times a day. The key is get back up. What else helps? Take control of your situation, positive attitude, staying calm, a sense of humor, have a support system, yoga, meditation, showering, bathing at night. I love that one, Brad. That's a great suggestion. Using aids that help, and good sleep habits. So this is often a question I get. How do I know if I'm getting better? Well, I learned a long time ago that to be a good husband, it's much better if I under-promise and over-deliver. And it's also true of being a good doctor. That if you and I decide that 50% better is our goal, the chance that you and I are going to be successful is much better than if I say, you know what, we're going to get this fixed tomorrow. Because that's not realistic. It's a process. So let's shoot for at least half better. So how do we grade that? So what I use is this functional capacity scale. And what I do is I ask patients to rate themselves where they are on their very worst day and where they are on their best day. And we look to pace so that we avoid the push and crash cycles where you work your tail off for a day, you go out, you get all the shopping done, you get all the cooking done for the week, but then you're down for 3 days. How many of you have had that experience? Right, so that's very common. So we want to avoid that phenomenon. The functional range, we want to look at, hang on, where is it? That's not it. Hang on, I'm missing a slide. Yeah, I'm missing a slide. But in any case, there's a slide from 1 to 5 that looks at, so 1 is you're in bed all day, so 10% energy day is you're in bed all day, you even have to have help with a bath. You can't even perform your own activities of daily living. A 3 is where you are able to participate, you're able to do all your activities of daily living, but you're basically spending at least half the day on the couch. You're usually having a good morning, but the afternoon you're wiped out. And then we try and figure out, okay, where you are on your worst day. And then we try and go to, okay, where are you on your best day? So 60% energy would be mild or no symptoms of rest with fairly good concentration for up to 45 minutes, cannot multitask, needs an afternoon rest, can do most activities of daily living except vacuuming, can walk 20 to 30 minutes per day, can do volunteer work, maximum total time 4 hours per week with flexible hours. And then gradually all the way up to 100% energy, which is no symptoms, excellent concentration, an overachiever. When was the last time any of you had a 10? Okay. So what we do then is I say, okay, let's say you range from 20 to 50%. Then we ask how many of those days in a week are 50% days, how many are 10% days or 20% days. And then the goal then is to move that up at least 1 notch every visit that we get together. Try and move up at least 1 from, if you're at 60% at your very best, we want to get you to 70%. If you are at your very worst in bed all day, we definitely want to get rid of those days. We want to try and manage those. So that's how I help my patients figure out, okay, am I getting better? And how do we measure better? It's functionally. Are we functioning better? I think that's the most reliable and ultimately that's what we're all about, is functional improvement. Education, there's lots of great information out there now. There didn't used to be, but Dysautonomia International has done a great job with putting out some very good pre-printed papers that you can print out and take to your doctor. 10 things to know about POTS. I mean, you really are the cutting edge of education. You have to educate your family. You have to educate your friends. You have to educate healthcare professionals who may not be as familiar about this. Luckily, the word is out. More and more primary care physicians and others do know about POTS. They don't fully understand it, but, well, none of us fully understand it. But I think the awareness is working. There's a very good book called Feeling Good, the New Mood Therapy, which I like and I recommend to patients. It talks about how to do your own cognitive behavioral therapy to manage those negative messages. How are we doing on time, Jenny?
Yeah, like 10 minutes.
Okay, so to manage those negative messages, when we get chronically ill, my experience is there are about 3 common messages that chronically ill people send themselves. I'm never getting better. I'm only getting worse. Nobody knows what's wrong with me. Anybody ever felt those things? So those are very common symptoms. And they are very destructive messages because they set us up to do worse. And so we need to have ready-made, ready-to-go messages to counteract those. When we begin, our brain begins to, first we have to become aware that we're having these kinds of messages, that we're getting worse. And we then have to, as soon as we start saying those to ourselves, we need to have a response. And one response is, okay, well maybe I don't feel good today, but it doesn't mean I won't feel better tomorrow. And I can do the following 3 to 5 things, and feel better right now. I can take a warm bath, I can drink some herbal tea, I can listen to Mozart, whatever it is for you. Make a list of 5 things that'll make you feel better right now. Stick it on your wall, stick it on your refrigerator, and when you begin to have these moments, look at that list. It's kind of what I remember a few years ago. I heard this psychologist who was talking about optimizing happiness, and it was pretty simple. He said, write down 10 things that make